All right, thank you all. Now that I sent everybody away, I think we'll have people filter back in, but get started with this talk and we'll be recorded so we can all review it. The topic near and dear to my heart is quality and process and review, and talk about why later potentially, but got a few speakers who are going to talk a little bit about some specifics here. First, we're going to have Dr. James Lamberg. He's a physician anesthesiologist, part of the Lancaster General Health Group for UPenn. Board certified in anesthesiology, critical care, perioperative echo, and patient safety. Serves as chair of the multidisciplinary peer review committee, as well as other various leadership roles in quality improvement committees. Current ATLS instructor and author of the Fundamentals of Critical Care Support textbook. Been selected as the top physician under 40 by the Pennsylvania Medical Society, involved in several hospital-wide safety projects, including leading the development of an airway response team, winning a hospital safety award last year. Worked as a critical care physician during COVID and has had leadership responsibilities as part of the COVID-19 Critical Care Task Force, and previously served as anesthesiology director for TrueLorn Board Review. Please join me in welcoming Dr. Lamberg.
All right, so we're going to be talking about peer review today, and just saying that phrase I know can bring up some anxiety for people. Hearing that one of your cases was sent to peer review is not really an exciting thing to hear. My email's here. I've been through the trials and tribulations of creating peer review committees at multiple institutions and doing some consulting for that. So if anyone has any questions about how to create a peer review committee, how to improve yours, and so forth, I'm here to help. Reach out to me via email. I can send you these slides as well. I don't have any disclosures. So clinical peer review, also known as quality review or simply peer review, is a requirement by the Joint Commission and CMS. It's where we look at our colleagues' clinical care specifically and determine if it was appropriate care. It's separated from behavioral issues, so if someone threw a scalpel in an operating room, that usually does not go through clinical peer review. That would be something that would go through like a chairman or a different kind of committee. So we're going to talk about a bunch of example cases here. So let's say, for example, you're sitting on a peer review committee at your institution and you get this mortality case. So a lot of the cases we get something bad happened or there was a mortality, and those cases get sent to peer review to look at. So we have an anesthesia call to the ICU to intubate a patient. This patient has a severe upper airway hemorrhage. It's like a posterior nosebleed that keeps bleeding. They can't control it. They're losing the airway. Anesthesia gives propofol, sucks, puts in an endotracheal tube, saves the day. Easy intubation, the SATs are good throughout. Over the next hour, the patient gets tachycardic. They have a fever, they're resistant to acetaminophen, they try some cooling. They're in the ICU. There's 2 or 3 different ICU physicians looking at this patient. They presume it's sepsis, we're in the ICU, they start treatment, antibiotics, fever's getting worse. Hypotension starts, vasopressors because it's sepsis. They become hemodynamically unstable, cardiac arrest, and then a month later on the review, it looks like maybe this might have been malignant hyperthermia and it was missed. So this is an example of what not to do or how to misstep. So the case gets sent to the clinical committee for the ICU physicians. The ICU physicians review this and say, well, anesthesia gave the succinylcholine, they're at fault for this mortality. So there's a blame pointed. They recommend putting these providers in a performance improvement program. And one of the providers involved has had issues before, so they suggest that provider maybe should get their privileges restricted. And now we're going to talk about how to not do this and ways to protect your institution with checks and balances so this kind of thing doesn't happen. It wouldn't be a safety presentation if we didn't quote something from To Err is Human. So the common initial reaction when an error occurs is to find someone to blame and point the finger at them. The 3 things I want you to remember from this presentation that we'll talk about and circle back to the end are it's important to get physicians, specifically anesthesiologists, onto these safety and review committees. That gives representation. The second is just culture is the way to do peer review these days. It's the new model, and we should be all moving towards that. The NPSF Just Culture tool, which I'll talk about, you can search for that online, but it's a very simple way to deal with these peer review cases. And then once you've determined if there's any system issues, you can focus on improving the system by using the Institute of Healthcare Improvement's Action Hierarchy tool. So, peer review committee, who do you want to put on this committee? Physicians, first off, is very important, and some institutions don't have physicians on committees that are reviewing physician cases. So it's important to try to get physicians onto these committees. And anesthesiologists are really uniquely qualified to be reviewing cases. We deal with safety every day. Patients are going to go to the operating room for surgery. We're the last step. We're the guardians determining if that patient can go to the operating room safely or if they need to be optimized further before going to the operating room. We also have a breadth of training and cover lots of different specialties: thoracic, OB, cardiac, peds. We know a little bit about all the different specialties. So when these peer review cases come from different specialties, we're able to navigate them. Also, the two biggest causes of major perioperative or major safety events in hospitals are related to surgical services and anesthesia. So those are medication related, specifically the ones we typically give in the operating room, and surgical services in general. Surgery is a high risk area, high stakes, issues tend to happen there, and we're already involved with them. Also, putting physicians on these committees ensures that you have physicians reviewing physician cases. Characteristics of a committee member, if you wanted to have ideal characteristics, first off would be someone willing to join the committee to begin with, and then you also want someone that's fair and impartial. So the Code of Conduct for U.S. judges has a nice outline of what fair and impartial means. It's a phrase that's said out loud, but going into what that actually means can be a little bit more complex. Fortunately, this Code of Conduct delineates that nicely. You want providers that understand just culture principles and are using the modern way of dealing with patient safety and not the old blaming way of dealing with it. And you want providers that can establish trust, show respect, and promote inclusion. We're dealing with issues sometimes between departments, so you want people that are going to be building sandcastles in a sandbox and not throwing sand at each other. Lastly, we want to make sure that we understand this is sensitive issues, and peer review is peer protected. There are several different laws. There's the MCARE law, the Patient Safety Quality Improvement Act. These things protect patient safety committees and patient safety discussions from the lawyers, basically. So everything's peer protected and not discoverable. So as long as you're following the right process for your peer review, you can remain protected and talk openly about these cases. We also have to keep in mind that with peer review, we're all humans, and humans are going to make mistakes. This is where just culture comes in. So just culture is the idea that, or the concept that directly opposes the old blame and shame model. You might be familiar with examples of the blame and shame model, like morbidity and mortality committee, where you put someone up in front of everyone and they throw fire at them and ask them why they did it this way and why they did it that way, and almost blame them for the cause of that case. We try not to do that anymore, and I know it's still done. We're trying to move forward and get towards a less punitive approach. So the goal of just culture is this fair and balanced accountability. Human error in particular is non-punitive, so you don't punish anyone for any kind of human error. But it also doesn't mean that this is a no-blame approach. There are still situations where providers are egregious or reckless, and we need to take steps, but it's important to differentiate those cases from the ones where we just have human error. And we also want to focus on improving the system as a whole. Just culture really tries to separate the outcomes of events from the behavior that led to them. So an example of that would be a horrible car crash. Just because a car crash happened at an intersection doesn't mean anyone was to blame. Maybe it was the stoplight that was out at the time, or maybe there was some other reason. But it doesn't necessarily mean that one of the drivers is to blame. And this kind of brings us into outcome bias, which is a big problem in patient safety and peer review. With outcome bias, most of the cases that come our way, something bad happened, a mortality, or someone at least thought something very bad happened. So right away, there's this outcome bias where you have a bad outcome, but you have to keep in mind that that doesn't mean there was bad behavior that led to that. On the flip side, just because the outcome was okay doesn't mean that the behavior was also okay. So an example of that's drunk driving. So just because you made it home safe after several beers at the bar doesn't mean it's okay to drunk drive. And in the same breath as that, we reject the idea of no harm, no foul when we're talking about patient safety and peer review. So near misses are just as important as actual misses. So just because we caught something last minute and no one was hurt doesn't mean we should report it and take steps to try to prevent that from happening next time. So the Just Culture tool, this is going to be the meat of everything I'm trying to share with you. This tool, again, you can search for online. It's part of the Institute of Healthcare Improvement and National Patient Safety Foundation, and they use a colloquial green light, yellow light, red light approach. We'll talk about the red light impaired practices, which is the easiest. This is where you don't take a case and send it to a committee to discuss. You just send it all the way to the top. An example would be a provider that's drunk at work, trying to practice medicine, or maybe someone that's intentionally trying to cause harm, like that anesthesiologist in Texas that was putting bupivacaine into IV bags. Those cases don't go to a committee to discuss, they just go straight up to the top. The green light side of it is the Met standard of care. These are cases where you review them quickly, everyone did everything right, and you would think you would want to move on and just close the case. But the important step here is to take the compassion that you have for your patients and turn it towards your colleagues. So we have what's called the second victim effect that can happen, a very bad outcome, a young child, a mom that passes away, something that's devastating. Providers are involved in this and they didn't do anything wrong, but they're gonna feel like they did something wrong. So it's important for us doing peer review when we see these cases to reach out to these providers and provide support for them to make sure they understand that they're doing the right thing and we're here to help each other. Now we're going to talk about the yellow light, which is most of what we deal with when we are in peer review committees. These are cases that get submitted to us where it looks like the standard of care wasn't met, or at least someone strongly feels that the standard of care wasn't met. When these cases get sent to us, the easiest way to deal with them is asking two structured questions. And this just provides a framework to get us going with how to do these peer review cases. It's not the end all be all, but it at least gets the conversation going and provides some objectivity. So first question here is the substitution test. You say, hey, I have, this physician did something that looks like it might be wrong. If I took 3 other anesthesiologists and put them in the same situation, what would they have done? This comes from the reasonable person standard in the legal realm, and basically you're saying what would your colleagues have done in the same situation. The next question is a test of intention, or intention test. This is where you ask if the provider knew, if the physician knew that there was some standard of care, some policy, some guideline, and they decided to skip that guideline anyway. So another way to say this is the provider ought to have known. This is also known as cutting corners. So yeah, I knew at the end of the case I wasn't supposed to take the EKGs and the blood pressure cuff off before extubating the patient, but we're just trying to speed up the day and I did it anyway. That's like an example of intentions. They knew there was a way to do it and they cut the corner anyway. And this is not the same as intention to cause harm. Intention to cause harm gets escalated immediately. This is intention to break the standard of care. So this is what the matrix looks like for the yellow, where it has the substitution test at the top, the intention test on the left, and based on the yes-no answers of these, it puts us into what we're gonna do. The bottom left here is human error, where we just console the provider, where we reach out to them and say, hey, mistakes happen, anyone could have done this. Let's talk about moving forward. The top left and bottom right corner slots are where we identify an opportunity for improvement. This is usually where we send a letter to a provider that says, hey, we thought you might have mixed up here. Here's a letter to remind you to do the right thing next time. And it's not punitive, it's just a educational tool. And then the top right is our last step. This is reserved for the most egregious issues where a provider knew there was a way to do this, did the opposite, and none of their colleagues would have done the same thing. And we're going to go through some examples of that too here. So also with just culture, when we're looking at that last matrix, we also want to think about the system shaping factors that are involved. There could be system factors that are driving a provider to make a choice or make the wrong choice, and we want to fix those system factors as we go forward too. The three behaviors in just culture and peer review that we talk about are human error, which cannot be prevented by punishment, meaning if a provider makes a mistake that any other provider makes, if you fire that provider, you're not going to fix the problem because the next provider might make the same mistake. At-risk behavior is the ones where we send coaching letters or emails or however your committee wants to do it, and we let them know that they didn't quite follow the standard of care. It wasn't a big deal. We want you to improve, and here's some options for how you can do that. And then we only use disciplinary sanction for reckless behavior. So going back to that first case example, the one that got sent to the ICU committee for review, we're going to send that same case now to the anesthesia committee for review. So was the standard of care met? They went to go intubate a patient, they used propofol and sucks and put a tube in. Yeah, that's what we do every day. Standard of care is met, we would close this case and move on. But let's say for sake of argument that we thought maybe the standard of care wasn't met and we want to review the case anyway. So let's look at the substitution test. You ask 3 of your colleagues, hey, if you had got called up to intubate a patient, what would you have done? And they all say, I would have given a muscle relaxant, an induction agent, put a tube in. So they all say the same thing. So the substitution test is a yes. So now we're in the first column on the left here. We look at the intention test and say, was there a policy, a protocol? Does the ASA have a standard that says you have to avoid succinylcholine? Not that I know of. So we're into the human error section here. So even in the worst case scenario, this would be human error. All right, example case number 2. This is a little bit different than the last one. We're talking about a patient who we do an upper endoscopy and then a lower endoscopy, just a standard double endoscopy. They have some typical medical problems. They're getting propofol, Tiva, and end-tidal CO2 nasal cannula like it's done at a lot of institutions. During the EGD or the upper part, the GI doctor says, hey, the stomach's full of food. I'm not going to do that part, but I'm going to do the colonoscopy. Do you want to intubate the patient? The provider says, well, they're already sedated, so we might as well just finish the colonoscopy. We don't need to do anything different. We'll be done in 10 minutes anyway. Turns out the patient vomits, desats, aspirates, ends up getting intubated, and is in the hospital for 2 days. So now we're asking the question, did we meet the standard of care? Probably not. Let's figure out where we land on that. So if you had 3 other competent anesthesiologists, would they have done the same thing? I would argue no, that this is outside of what most people would do. If you knew you had a full stomach, you'd probably intubate a patient. Intention test, is there a standard of care for this? Yeah, there's guidelines that say if you have a full stomach, you intubate a patient and don't keep providing sedation. So this would be an example of reckless behavior. The provider knowingly went outside of the standard of care, and other providers probably wouldn't have done the same thing. So an example of, let me go back, of how we could deal with this with disciplinary action is we could just review the cases for this provider for the next 3 months and make sure that they're following NPO guidelines. So let's revisit that case 1 here from a third approach. So this one is gets sent up to the highest peer review committee. So some institutions have multiple committees. So this large committee is now reviewing that first case, the malignant hyperthermia one, to determine if it was a misdiagnosis by the ICU team and if they didn't meet the standard of care. So substitution test. If we asked 3 competent critical care physicians, what would they have done? meaning they have a case that looks like sepsis, they have a fever. Would they have thought it was sepsis? Or would they have thought maybe this is this rare malignant hyperthermia thing? Well, we kind of know the answer there because in this scenario, it was missed by multiple providers already. So we have our substitution test already done for us. Multiple people missed this. So it wasn't, we're in the left column here again. An intention test, is there some kind of standard of care or protocol for febrile patients to get a malignant hyperthermia differential or workup? At least not at my institution or anywhere I'm aware of. So this would fall under, again, human error. But it was a bad outcome and we missed something. So how can we prevent this from happening in the future? And one of the easiest ways to do that is to look at system improvement processes. And there's several different hierarchy of controls matrices that are available to show how this is done. And I'm going to show you just one set of those matrices here. And this comes from the ISMP has hierarchy of controls, and the National Highway Transportation has hierarchy of controls. This is all a systems engineering design that is now fed down into medicine, and we're using ways to improve systems that come from like automotive and other different organizations. And the idea is you don't punish the individual providers when these mistakes happen, but you look for ways to fix the system that doesn't rely on those providers. So the most effective solutions are going to be solutions that don't rely on humans, and the least effective ones are ones that rely on humans because we're fallible. So an example of some of the least effective options here, I'm sorry if that's difficult to see, are things like sending an email, just telling providers don't do that again, maybe putting up like an audible warning sticker on something. These things just really aren't very reliable. More intermediate actions are things like creating redundancy, using the electronic record to leverage solutions, cognitive aids. So I heard the Stanford emergency manual talked about today. This would be a more intermediate action to prevent issues from happening in the future. And then the stronger actions are things where you're changing the whole architecture of the system and creating forcing functions and engineering controls where there's no way that a human could screw it up. So if it says enter a number 1 through 10 and they start putting in letters, it's not going to let them enter the letters. It's only going to accept numbers. So you create some way that prevents humans from making mistakes. So talking about that malignant hyperthermia issue, what would be some ways that we can improve that case? So sending an email to providers, sure, that might help in the short period because it's going to remind those providers about this possible thing. But if your hospital has high turnover or 2 years down the road, people are just not going to remember that email or it's not going to exist anymore. An educational lecture might be a better way to try to prevent future issues with malignant hyperthermia getting missed. But an even better way might be to create an EMR flag where you leverage your electronic medical record, where if certain criteria are met, it pulls up a flag or a BPA or best practice advisory that says, hey, have you thought about malignant hyperthermia? Because in that case, it doesn't matter which providers are at your institution. They could be old providers, new providers, anyone. That flag is going to come up and remind them, and you don't have to rely on human memory for that. So I actually cruised through that pretty quick. In summary, we want to encourage physicians and anesthesiologists to join your peer review committees and your safety organizations. You want to try to learn about these just culture principles, in particular that just culture tool, because it's a great framework for getting you started for dealing with these questions. And also the action hierarchy tool from the Institute of Healthcare Improvement is going to provide you a framework for how to fix system issues that come up. And again, my email's here. If you have any questions about doing peer review at your own institution, feel free to reach out to me. I'm happy to help. Oh, one last thing too. There's like 40 more slides here. If there's an electronic version of this that are getting sent out on how to create a peer review program at your institution, how to move to just culture, how to adjudicate cases and send letters or nastygrams to people. I just created all that and put it in here so it's available for everyone.
Excellent. Thank you, Dr. Lamberg. Great start to the session. We're going to follow it up with Dr. Mike Fabro, cardiothoracic anesthesiologist at University of Miami and chief of cardiothoracic anesthesia at UM Hospital. Also medical director for perioperative services, associate professor there, holds an MBA as well from the University of Miami. Research interests are in coagulation management and percutaneous heart valve procedures, but also dedicated teacher, receiving multiple teaching awards and serves several leadership roles around the residency and hospital. My pleasure to introduce Dr. Fabro.
Thank you. Good afternoon, everyone. Congrats for making it to the end on a Monday. The best part about doing these things is everyone makes you sound like you're amazing, so that was a nice introduction. Thank you. I guess the slides are coming up here. Perfect. So I also want to thank the AOCA for inviting me to speak, and the incoming president, Jen Hargrave. She's been very nice to me, and this is a really well done conference. I've been coming for a few years now, and I really enjoy coming to it, and I'm very grateful that I get to speak at it. I was asked to speak about the perils, pitfalls, and advantages of safe reporting systems. I think this ties in a little bit to James' talk, and I'm going to touch on some peer review a little bit. As Patrick was mentioning, I serve as the perioperative medical director, and I sit on the MCRC and help co-lead that team. So in those roles, I review all the quality related issues and sit on some of the U.S. News World Report quality services that task force that we've put together. So I'm using or involved in this safety reporting system for our own institution quite a bit, and I have no relevant disclosures. I do have some learning objectives here. I'm just going to outline basically the reporting process very briefly. Most of us are aware how this all works, but I am going to talk about it from a broad view. I'm going to talk about very briefly some of the objectives. I'm going to spend most of my time talking about some of the disadvantages and legal implications of these safety reporting systems, and finish with just kind of highlighting what I think a good safety reporting system or quality process looks like for an organization. So what is a safety reporting system? I mean, this is just taken right off the Agency for Healthcare and Quality Research Institute website. They say, it's a non-punitive, voluntary, and I put voluntary there in quotation marks, system of, healthcare providers generating reports for the purpose of collecting these reports to track adverse events and ultimately improving patient safety. I think this is kind of obvious. The reason I put voluntary there in quotation marks, I'm sure every one of your organizations has this, as it's a CMS requirement, so it's not really all that voluntary. And I could have probably put non-punitive in quotation marks too, because there can be punitive aspects of this too, although that's not the intent. So what should be reported? When I was putting this talk together, I walked down to the risk management office, and Lisette Rodriguez, who also serves on our general counsel as an attorney, leads our risk management program. I said, well, what are we supposed to be reporting? I mean, I can't find a good answer. And she said, you should report anything that's unexpected. And she gave me many examples. And when we look at some of the little bit of research that's out there, they highlight some of the things that they expect to be reported. And it's really just any unexpected outcome. A major bleeding event during surgery, hospital-acquired infection, really just anything that happens during the course of patient care that was not anticipated. And so, as you can imagine, in the course of a busy operating room, there should be many, many, many reports being generated, which is often not the case, and I'm going to talk about why some of that happens. I'm just going to briefly mention a case here because I think it's a good starting place to talk about some of these issues. So I just made an age up, but this is somewhat similar to a case we were involved in. A 78-year-old gentleman comes in having a abdominal exploration after having a major abdominal surgery, and there was some controversy about whether or not there was a retained instrument. And the hospital had a policy that there's an incident report generated whenever the instrument count is off, and so an incident report was generated on this case despite some denial that there was actually a retained instrument. I'll just point out that some of these issues in certain states, particularly the state of Florida, are never events, and it's actually a code 15, so retained instrument, wrong-sided site surgery. These things are mandatory report to the health board, and in the state of Florida actually have a mandatory on-site visit. So there's obviously incentive for not having these events or admitting to having these events. So anyway, an incident report is generated. What happens next? So this is a very broad overview of the process. I think James touched on some of this. I'm not going to get into the granular aspects, but basically, whenever someone generates a report, it goes to a risk management office. This could be on a small scale, just the CMO, or there could be an entire risk management team, or if a very big organization, they may even have actually attorneys doing the risk management work. And there's usually some very cursory fact-finding investigation that's done. Oftentimes, they'll look at the reports and push them to the side. This doesn't need to be looked in further. Sometimes they'll contact the people involved or the report generator and just ask some very basic information. And then they really make a decision. Okay, there's nothing here, we're going to shelf it, we're not going to go any further. Or they really have one of three processes they can go down. One is they can do their own investigation into the situation, which usually involves calling people down to the risk management office, asking more details. They may ask questions of people that are mentioned in the report or not mentioned in the report. And they really just kind of dig and fact find and do their own investigation. The other alternative is if they believe there's a provider-related issue, it can be sent to peer review. Peer review is often reserved for physicians, although bigger organizations may have peer review processes for nursing or even nurse practitioners. It really just depends on how it's set up. If they don't choose to do either of those and they believe that there's really a systems-related issue, or there is a person involved that does not come under the purview of one of the peer review committees, they can then forward that to a root cause analysis, which is usually a team of people, if you've never been involved in these, where they basically do a much similar thing and really kind of try and hone down some of the systems related issues by asking people what happened and what was taking place during whatever the event was. And the idea is at the end of all of these activities, and they can use any combination of the three, that they create some system-based or practice-based changes or education, again, education being in quotation marks there, that result in some improved patient safety. I put education in quotation marks because, as James was mentioning, these things often come in the form of an email, either through your chairperson or directly to you, and it is a paper trail. I mean, it is supposed to be non-punitive, but, sort of the dark side of this, if you will, is if you're having a lot of issues, this paper trail becomes really important for an organization as they want to move forward with disciplinary action. So that's kind of how this all works, which most of us already knew. I think the bigger question is, does it actually work? Does it improve quality? And this is a much harder question to answer. One, since it's required by CMS, doing any sort of before or after work where you take a system that didn't have incident reporting and now they do and look at their major quality metrics is a little challenging. Also, doing this in a randomized way is nearly impossible. So as Patrick mentioned, I did an MBA. I spent a lot of time thinking about other healthcare delivery systems and how, say, the UK or Canada delivers healthcare versus the US, and there's a lot of differences. And one of the real key advantages of having a single payer system like they do in UK is they have a lot of data, particularly a lot of quality and outcome data. And this is a good place for us to go looking at outcomes and looking at large data sets on an entire country of people. And this is just a paper published in British Journal of Medicine, which basically showed that as the incident reporting rates went up, they had a decreased number of never events. In this particular paper, they were looking at patient falls. And this was over 180 hospitals, and many, many incident reports were included in this study. It's correlation data. It's not great data. I don't know what to take away from it, other than there seems to be some relationship between the number of incident reports that are generated and major outcomes like patient falls or major patient injuries like patient falls. So if they work, what are the limitations and why do we not use them more? And I was trying to think of the various pitfalls in my own life and achieving my own goals, and my cell phone is a major hindrance to that. But these safety reporting systems have their own set of pitfalls, and I'll go into them. So let's contrast the NHS data and go to US data. So this is the Office of Inspector General, and this was just basically a study of a similar number of hospitals trying to look at what are the issues with incident reporting, how do systems use them, who's filling these reports out, and what is the purpose as viewed by the administrators. And there were some probably 3 really important key findings, I think, that were published on this. One that might be very obvious is that nurses were really the only ones filling them out. And I think if you are involved in these reporting reviews or quality reviews for your own organization, you'll probably find something similar. I think that's changing, but by and large, physicians do not participate in this at nearly as much the rate that nurses participate in it. Which is interesting because when administrators were polled at these organizations, they were very forthcoming in saying that, look, most of our quality foundation is these incident reports. What quality initiatives we take on come through our incident reporting system. So if the incidents are not being reported and the administrators need this for their quality initiatives that they support, then that creates a real issue. And probably the biggest issue of them all is that major adverse events like hospital-acquired infections, major bleeding events, readmission, all these things we're very interested in as organizations were grossly underreported. Anywhere near 75 to 80% of them were not reported at all in this study. So why is this happening? Well, there's a lot of reasons why these incident reporting systems don't work. One of the key things that I think has been pointed out is this lack of feedback. So I'm an anesthesiologist or I'm a surgeon, and I take the time to navigate this cumbersome system to generate a report on my patient or this patient outcome, and then I never hear anything back. And this is a real problem, and it's such a problem that the AHRQ is actually supporting Cedars-Sinai with several $1 million to look at a feedback system and to publish on a feedback system that may actually increase the number of reports they get from their organization. Another issue with these systems is the misuse of them, and this is something risk management deals with quite a bit. Nurses using, I shouldn't pick on nurses, people in general, using them to point out people that are lazy or interactions that they did not necessarily deem as favorable, although they weren't unprofessional. And this creates a lot of workload for the risk management services. So the misuse of these systems is also one of the reasons why, one, they're not used, and two, they don't always work. And I think this is pretty timely. There's certainly been some bias identified in these safety reporting systems. This is just a group of authors that pulled out 500 incident reports and saw a very disproportionate number of incident reports being filled out on female and ethnic providers, which is concerning because that's not the intent, obviously, of these systems. And so the bias is another problem. And then James touched on this briefly. The discoverability. Now, James mentioned that there are some safety nets in place, and there are for these quality processes as they take place in an organization, but it's not clear in every state. And this is Amendment 7 in the state of Florida, which was ruled on in 2017 by the Supreme Court, that said, plaintiff lawyers should have access to this. And that was eventually overturned in 2019 by the District of Appeals, but it's still very gray in the state of Florida. And there's many other states that have these same issues. And just so you know, the way this typically will play out is, let's say you have an issue, or a surgeon has an issue and you're involved in a case, and there's some internal investigation or there's even depositions that are given. Typically what will happen is, the lawyer representing whoever's being sued, whether it's you, the hospital, or a surgeon or ICU doctor, or whatever it be, will typically object to questions about activities or statements that occurred within the peer review setting. But the plaintiff's lawyers will then push you to answer those questions, and then they will take that deposition in front of a judge and let the judge deem what is admissible or not admissible in a court. So, I mean, it's a little scary. This is obviously in conflict with what CMS or the idea of these safety reporting initiatives are, but nonetheless, it's a reality that we live in. And there are some protections against this that I'm going to talk about in just a second. So just to recap the issues, there's poor adoption, heavy reliance on administrators for these reports to improve their organizational quality. There's misuse, there's lack of feedback, there's bias, and there's medical legal uncertainty. And these are really all the pitfalls that surround these quality processes. So what does a good reporting system look like? I use this painting in like every talk I do because I'm fascinated by it. This is a George Seurat, which many of you have seen at the Chicago Art Institute. The bottom left is the masterpiece. The ones surrounding it are the studies that he did. You can find it various art places like the Met and et cetera. And you know, it's just a bunch of dots that creates this amazing image. And as you take the dots away, the image looks very different. And this, you can relate this to, you know, homeostasis, coagulation, but really it re-emphasizes the point, I think, that you need all the components to really have a beautiful painting or a good system. So what are these components? At risk of being cliche, you know, leadership is key. I think it's a very sort of open statement, but there actually is some data on this. This is a German hospital series where they polled CMOs at these hospitals and said, you know, are your leaders really invested in quality? And all the CMOs that said, yes, our leaders are really invested in quality, they went back and looked at the number of incident reports that organization had. And it was true, those CMOs that felt that there was a lot of investment in quality had very high numbers of incident reports. And you know, I think every organization gets creative in their leadership style and their leadership systems, but you know, with executive boards and such, I think it's really hard to get away from top-down management. I mean, it really comes from the top. So leadership is key. You know, you need administrative buy-in, administrative push for these incident reports. I mean, in theory, someone should actually be looking at the number of reports that are being generated, and not just the number of reports that are being generated, who is generating these reports. And we have our own issues in our own organization. I mean, they're almost virtually never filled out by surgeons because surgeons never have unexpected outcomes. They are filled out with some regularity by anesthesia, but not nearly as much as our organization would like to see. And they continue to be predominantly used by nurses. One of the key issues with all these systems, if you've ever tried to fill them out, you know, RL6, Quantros, whatever your organization calls it, is they can be quite cumbersome sometimes. You have to find the icon. You might have to find someone who like knows how to use it to show you how to use it, and that is a major limitation to them. Ideally, they should be as easy to use as possible. You really need to be giving people feedback. And as I've been joining our current chair of our own peer review process, we've been really pushing to give people feedback. Hey, you had a case that was reviewed, you know, there were no issues, some form of feedback, or you filled an incident report out on this is what we found, to try and continue people to participate in the quality process. I think you really need to overemphasize the lack of a punitive component, even though, you know, I alluded there may be some punitive elements, is really not the intent. The intent here is that everyone should be interested in quality. We should all be participating in these processes and trying to improve patient quality, because that's what we want at the end of the day. We want our patients to do well. And the last point is, I think every system needs a process in place to protect themselves, and there's a lot of talk around this. And really what's coming out of it is these patient safety organizations. These are essentially external auditors. So you just take your incident reports and you funnel them to these PSOs. And the reason why this works is there is clear federal protection for these PSOs against discoverability. So if the PSO is the one performing your quality review, or it's being done under the umbrella of a PSO, then what James was mentioning is very true. It's very difficult for plaintiffs' attorneys to get access to that. And there are a number of PSOs. I'll just point a couple out. The American Osteopathic Association actually has a PSO, and the Anesthesia Quality Institute has a PSO, or is a PSO. Last thing I'll probably point out what not to do. What not to do is if you have a quality related issue and you choose not to fill an incident report about it, and then you get some pre-suit letter or some inclination that there is going to be a suit, or the surgeon you did the case with tells you they got a pre-suit letter, that is not the time to go back and fill out an incident report. That can create some issues for your organization. And frankly, it doesn't look great. So, I would refrain from doing that. The last thing I'll point out, I think that if you're going to talk about a computer system, you are obligated to mention AI in 2022. So I'll go ahead and just mention AI. As organizations adopt more of this AI technology, we're using, 3M at our health system now, and they're extracting these diagnostic codes automatically. It's possible that we may see in the future where you get a notification that says, hey, this diagnostic code or this verbiage was extracted from your anesthetic medical record, and we think you should consider filling out an incident report. And I'm sure we will have some iteration of that in the not too distant future. So I'll finish there. Safety first. Thank you. And James and I will be happy to answer some questions.
Great. Thank you so much. Quality is important to all of us, and I know I joke sometimes with my family that, the meetings I have to go to or get to go to support the institution for things like quality. It's why every boy dreams of being a doctor, none of us went to medicine, hopefully none of us went to medicine to participate in quality improvement and process review, but I think when you find it as a passion, it really validates a lot of the other work. So I'd like to open up to questions. I've got a few things to say too, but I'd love to hear from the audience.
Thanks for the presentation. Both were great. Just two questions, and this is directed to anyone. Can you hear me? All right. Yeah. One is a legal question. I was under the impression that with peer review, there's state laws and a federal law, which I can't remember the name of, but my recollection is the federal law was very robust as it relates to peer review and overrode state law. Do you know if that's the case?
Well, I can comment on this. We have a pretty high volume cardiac surgical practice, and we've had a number of issues come up over the years, particularly in the last couple of years, and it's very unclear. And in theory, yes, but when the lawyers argue about it, there's never a clear answer. They're going to have you answer the questions, and they're going to put it in front of a judge, and they're going to let a judge decide.
The second question is, having served on peer review committees, there's a lot of gray, obviously, with every case you review. There's not so cut and dried to put in any one of these categories. I'll give a good example. You have a spine surgeon, and they have a dural tear, and that's a known complication, so it goes to peer reports generated. Peer review does a review, and they say, no, it's a known complication, that's fine. But if it happens again and again and again, at some point you got to say, well, it's a known complication, but it's happening too often. So how do you handle that situation?
Yeah, that's a great question. So creating checks and balances in general in your system and layers in your system are going to help with that. So yeah, a one-off complication from some kind of surgical procedure, that's going to happen. And you're going to have gray areas here too. And reviewing those at multiple levels, so at the surgical level, and then having a bigger committee that reviews all types of cases is going to help put more eyes on these. And having a committee in general prevents just one or two people or specialists within their own specialty dominating the conversation. But ultimately, your organization has to track and trend these kind of complications and then compare them against national standards. So some different specialties like cardiac surgery have STS data where they have to meet certain standards, and it's followed from a major organization Trauma is another good example of an organization that reports to statewide and national, and they have to be within certain bounds, and if they're not within certain bounds, their organizations come visit them to try to figure out how to get them back in line. But not all specialties have that, so it falls on the organization or the hospital themselves to track and trend these things and see if they're within what would be an expected standard.
Yeah, and your question about protection and peer review is very important, and we talk about that, and we really have to educate our trainees that it's important. It's protected within the peer review process, right? But not on the elevator and not outside the peer review process. And that's not a physical location either, right? Like M&M itself is billed as what happens in here stays in here, but even that isn't necessarily protected the way we think it is. And we also have to be careful. I mean, just well-meaning people having honest discussions out in the open about things, and all of that, right, is potentially like capturable. So it's just, I think, not having gone through that necessarily, I think we have to be very, very careful with that. For me, and this is a tough question, and neither of you, I don't think, are attorneys, but we talk a lot about civil liability and litigation, and a relatively high-profile case that was litigated recently involved criminal charges being filed. Now, obviously, there's nuance and other factors, but do you see that being something that we'll be spending more time talking about in the future, with well-meaning, honest mistakes leading to potential criminal charges? Or is that something that...
That's an amazing question. You're talking about the Redondavat case, and yeah, that shook the patient safety world and nursing community as something that probably shouldn't happen. The idea is you're creating a system where people want to report events that happen. It's supposed to be non-punitive, and you're not expecting any of this to end up in a lawyer's pocketbook. And having a DA go after a medical provider is not something we can really protect against right now that I'm aware of. Hopefully they know better than to attack our community when we're trying to improve safety for everyone, because I think that will not be good for the community and for healthcare in general. That's, of course, my opinion. But if they can do it, I think it's going to happen again.
Yeah, I think organizations are concerned about it for sure. I know one of the things that we've done recently, if there's a major event and there is some controversy around that event, they will actually right out of the gate hire external counsel to do their own investigation and advise them. One, it provides them some protections with the attorney-client privilege, but also it allows an outside counsel to look at it and say, this is what we expect to happen with this, and this is probably what you should do to get in preparation for what's coming. So definitely some concern around that.
Yeah, that's a great point Mike makes. And the slide you had on what typically happens when a case gets submitted, and risk management is the first step in involvement, and any peer review committee or safety group should have risk management directly working with them. So if you have a case that looks like it might end up being litigated, you should immediately work with your risk managers to try to figure out how to deal with that.
Yeah, it's a tough call. I know a lot of people express concern about this, but I think the fear of the unknown is the biggest part, right? Like we all make, like we talked about, human error is a part of everything, and we certainly don't want that to impact our care moving forward, because I think when we practice in that, CYA, for lack of a better phrase, then we don't deliver as good a care and maybe cost more to patients as well. I was curious because we have a large institution. I think both of yours are large as well. The size of the institution and the reporting system, does that correlate at all? So do smaller institutions, ASCs, potentially it's harder to report things anonymously, for instance? I mean, do you think that impacts the quality of say, relative to the size of the institution?
Yeah, that opens up a lot of questions there. So some small organizations, or if you're a small specialty with 2 or 3 providers and you want to try to do the substitution test and you only have 2 of your colleagues, it's going to be difficult to do that. So using external reviewers will help reduce the bias there. But on the flip side, when we're talking about reporting cases, improving the safety overall, there's this theory, it's called Goodhart's Law, And the idea is, if you know what the target is, you're going to cater to that. So an example is, if you think that creating a lot of safety reports is going to improve safety, your organization might say, now you have to report all these safety things, and that might not be useful at all. So yeah, there's going to be some bias with small organizations. There might be some fear at ASCs if it's owned by surgeons and the anesthesiologists want to report something, they're worried about retaliation, or maybe they'll get moved out as a group and another group gets moved in. These are really difficult questions that I don't necessarily have the answer for. For larger organizations, I think it's important to not do anonymous reporting, but do confidential reporting. So anonymous reporting doesn't put a name on it, and it makes it difficult to determine the authenticity of what's being sent into you. Confidential reporting lets you know who the provider is, but it's not shared with anyone else. So that way you can give feedback to the provider and let them know you've addressed these concerns that they have, but you're also not sharing that information with anyone else. That's a little bit more difficult to do at these small levels.
Yeah, I think those are all good points. I think, this is a very resource-intensive process, and the more reports you have, the more resources it needs. And that's, it's like cardiac surgery, more is not always better. And, sometimes what happens, like in our own organization, we have a very, granular process. There's a subcommittee, and then it can get bumped up before it actually ends up at peer review. And some of that process can be very nebulous. Even who's involved in that process sometimes is not very clear. And so I think that can, in some ways, perverse the whole process.
Those are important distinctions. Any follow-up questions from the audience? Anyone want to tell a tale?
Just more of a comment. I think with this whole discussion, so often what we see is patient crumping on the floor, several hours go by. It was slow in recognizing the unfolding catastrophe there. And you discuss this in peer review. It's so important to close the loop, and in terms of system improvement, educating nursing, educating the support staff, or figuring out how it's not just the attending, it's the whole system, the floor, everybody involved in the care of the patient, and then not only suggesting those changes, but ensuring that they're actually implemented.
Absolutely. Great comment.
Agreed. And if your organization has the resources, I think having, again, nurse practitioner or even nursing peer review is helpful to identify some of those issues, particularly with individual providers.
Yeah, I agree. Yes, sir.
A couple things. One is, why is on peer review the assumption that somebody did something wrong, say for example your MH case, that teaching is what's necessary to happen, when in reality there are instances where it's an act of God. But in your demonstration, everything revolved around intent, whether there was or was not, but it was 100% that somebody did something wrong. When in that scenario, did really anybody do anything wrong?
I think I understand your question, which is when reports are submitted, they have a bias to them that someone did something wrong, and that's why generally people submit reports. Is that what you're getting at?
Well, it's not just that, but it was at the end of it when it was decided that that nothing really with the MH scenario was that nothing really happened. Nobody did anything wrong, but somebody got an email or a letter stating to get better educated.
Oh, so in that scenario, the MH one, we wouldn't send a letter for that. So that was human error.
Is it human error though, or is it the?
Which one?
I think the consideration, he said he took it as if they had decided there was a yellow status, right?
Yeah, so even if we said that we were outside of it was still human error in that case, because we had other providers that did the same thing, and no one was intentionally breaking a standard of care there. So in that case, we don't send letters. It's not punitive.
I understand that it's not punitive, but your assumption is that there was human error, when in reality, the only possible human error that really occurred was the patient.
Yeah, no, I see. I was playing devil's advocate as
Okay.
if that case was submitted and we had to review it for, maybe I should have been more clear in my slide about that. But yeah, it was appropriate care, that case, the anesthesiology team. And
And the ICU team. I mean,
Correct.
It
Yes.
was a zebra.
exactly. But it was still missed somewhere, which doesn't mean the providers did anything, but there's ways to improve the system coming
Oh.
out of that event. But yes, appropriate care, I agree.
And then his first question was about repetitive, how did you say it? Was not really reoccurrent complications. Generally, and it was a neurosurgeon, generally in my experience is the hospital was poo-pooing it because it was a financially lucrative surgeon providing the care.
Yeah, that does get to the reality of some of these situations. You can track and trend them, but is the hospital willing to make the next step to do what's right? And that's not necessarily always the case. We want to think that it's the right case, but yeah.
I mean, there's no doubt there's executive board influence. I mean, the CMO reports to the MEC, the CEO reports to the executive board. I mean, they definitely have influence over this.
To belabor things here, one other quick question. The case where there was a missed lap count, you know, I don't know if I understood it correctly. The surgeon was 5 days later, came back and tried to hide the fact that he's taking out a lap sponge. Is that, to me, that's almost like a criminal.
It was a hypothetical scenario.
Yeah, to me, that would be immediately kicked up as. There's a lot of issues
that
there.
borders on reckless behavior, but also intent to cause harm if you're hiding these things. This gets a little gray, and it kind of jumps into something else that was brought up is if you have a culture of safety at your institution, people are going to be willing to report each other, and they feel that when these reports go to committee, they're going to do the right thing with them. They're going to follow an algorithm and try to do what's best. But if you don't have a culture of safety and there's blame and shame at your institution, and you're the provider and you would be self-reporting these issues, there's incentive for you to not report those issues and hide them. So that really gets into, like, are you intentionally hiding it to be a bad person, or is the system doing you wrong and creating this blame and shame situation where you're so scared that you're going to get fired that the risk benefit is that you would rather hide the mistake. So it's a very difficult thing that we deal with, and there's a lot of gray area there. But you know, they try to say create a culture of safety, which sounds much easier than done. But at the institutions that don't have a culture of safety, you see these things a lot more.
I was curious. So I think the worst text I could get would be one of my partners or colleagues saying, "Hey, can we talk about a case that you did?" Because it would mean I had a patient who had an outcome that I didn't know about, right? Like the surprise of that. So I'm curious then how, like, I know why I got into quality and process and this sort of review, but what do you think drives people or yourself to get into that? Dr. Lamberg, what got you to get into this sort of review process?
So I was interested in patient safety and started moving into it, and then found out about peer review. And it's, you know, how do you make the jump to being the cop or the internal affairs? Or that's the perception. Like, it's not an exciting role. You're kind of seen as the enemy. But the reality is you're really not. You're trying to help the system and the providers. So I think having my own events happen during residency in a program that had a lot of blame and shame and wondering if there was a better way to do it was one step that got me interested in it. And now being able to reach out to providers that have issues with the second victim effect has been really wonderful, because we can provide support and compassion for our own physicians within our groups and let them know, hey, we're all on the same team. When bad things happen, we're going to do the best to move forward, and we don't have physicians who are talking about committing suicide or jumping out of medicine completely.
Dr. Fabreau, what about you?
Well, I mean, part of it is just never saying no, being asked to do certain things. But I think I work with a lot of at-risk surgeons, or service lines, cardiac surgery, neurosurgery, our thoracic surgery group, and we have gone down the road of a lot of different quality projects, enhanced recovery after cardiac surgery, and being involved in this has been nice because it's just another way to partner with them and say, you know, these reports and putting, you know, going through the peer review process is something that is going to make us all better, and partnering with them on that has been very rewarding for me.
I think you've highlighted that. This is a great way to help be advocates for our partners and our teammates, as well as to help make the system better. Any further questions for Dr. Lamberg or Fabro today? All right, well, we'll finish a few minutes early. I appreciate everyone's attention, and let's give a round of applause to our speakers.